ART and a late stage of disease with less than 200 copies. And what happened in this first two trimester, we didn't see at the beginning a decrease in people with on ART in the first trimester. However, in the second trimester in 2002, we started to see the decrease, and this is going probably to decrease even more with the following months. It will depend according to how the COVID pandemic is going to be in the following weeks. We have a concentrated, just to remember that our epidemic is concentrated in MSM population, sex workers, and transgender population mostly. So, what about HIV testing and new cases in this situation? Well, this is in Mexico, in the whole country, and as you can see, if you compare the first and second trimester of 2019 to 2020, you see the decrease of testing that has decreased a lot because of the quarantine and people that are not willing to go to health facilities to testing, and this has traduced in a decrease also in the new cases. And although 2020 has not finished yet, you can see that according to the trimesters in this year, compared to 2019, the reduction of the new cases of HIV has decreased a lot, probably due to less testing. What about Mexico City? Well, Mexico City, the Clínica Condesa has increased, has done a tremendous effort to increase the testing, and the last year they almost got tested more 40,000 people, and however the new cases in Mexico City of HIV, you can see that 2020, although as I say, this is data up to March, it's at the beginning of the year, it will probably less new cases due to less testing overall Mexico and Mexico City. So what is the situation of the COVID-19 pandemic in our country? As you probably know, COVID-19 has hit our country really bad. And the first case was documented in February 27. On mid-March, our institution, Nutrición and Int'l, were converted into COVID-only hospital, and therefore these two clinics of HIV have almost stopped. And in March 23, local transmission of COVID was documented, and by presidential order, they determined that employers could go and leave because of risk factors and comorbidities, and that made that the hospitals had less human resources than usually they do, although they had more demand for care. And Clínica Condesa stopped the regular visits for temporal suspension of the clinical consults for those who were stable. I will explain this further. And the lockdown officially started on April 21, and then reopened slowly in May 30th. Up to now, we have confirmed more than 6,000 people that had COVID, and with a high mortality of more of 10%, even a slight more than 10%. And we probably will reach next week the 7,000. You have to remember that in Mexico, availability of testing for COVID, it's only for symptomatic patients, and we have a lot of barriers for testing, and that is one of the explanations why this rate is so high, among other reasons. So this is the situation in Mexico City, and as you can see, Mexico City, as a large city around the world, has been affected severely by COVID. Now this is just starting to descend, although the city opened in May. We have more than 8,000 deaths. And when we cross the database with people living with HIV, we noticed that 524 people living with HIV in Mexico City, that is less than 1%, was confirmed with SARS-CoV-2 infection, and of those 61, that is the 12% were dead because of COVID. However, when we cross the database with the Ministry of Health program of HIV, we registered 291 cases with 18 deaths. What were the actions taken? Well, the actions taken in March 2020 in Clínica Condesa, which is the largest clinic that has 2 facilities. We dispensed for more than 4 to 6 months of ART. They prioritize the admission and readmission of patients. I will explain this in the following slides. And they temporarily suspended the viral load and CD4 cell count determination, except for special patients. And they temporarily stopped the consults for undetectable patients that had CD4 cell counts above 200, but they initiated virtually on July. So this is a very interesting slide in which you can compare 2019 and 2020. And you can see the new admissions even increased at the beginning of the year, 12%. And this is also reflected in active patients. We defined as those who had at least one consult or clinical visit in 1 year. However, readmissions, that are patients that at some point came up to the clinic to diagnose or newly diagnosed and started ART, but then got lost to follow up. However, in the months of April and May, many patients, 80% of increase compared to the previous year, came again to start their clinical visits and start on the ART, probably because it was initially said that people living with HIV with advanced stage of disease less than 200 CD4 cell counts were at risk of having being more affected by COVID, and also because at the beginning the information was that probably ART was effective against COVID, and that's why many people seek again for clinical attention in the HIV care facilities. And what were the actions taken in the other 2 clinics in Nutrición and in Sieni? Both hospitals are designated and still are for COVID only. So the outpatient facilities were totally closed. We gave medication for more than 3 months to all our patients. We suspended the laboratory service for viral load and CD4 cell counts. Although we are a reference laboratory, both institutions, we do give optional mental health and virtual consults, and at the end of June, CNE opened the laboratory just by appointment, and we started to reopen our clinical visits in the last month in August. So what were the consequences of that? We have in Nutrición more than 2,000 active patients. We had almost none new admissions were in January and in February, and as you can see, normally we have between 100 and 150 patients, new patients every year, and we have by up to now in the last month, we tested viral load in the 50% of our active patients, and unfortunately 5% are no longer undetectable, and we have 62 patients that are now lost to follow-up and have not picked up ART medication. In CNE, what happened, they have less active patients and a significant decrease when compared to 2019, and this is due to loss to follow-up and some deaths. And if you compare the proportion of loss to follow-up and compared to the previous year, you can see that it is the double. So another impact of the COVID pandemic is that we don't have a PrEP program for our patients. So in PrEP was the only way to get PrEP, and this has suspended because of the COVID-19, and also the hepatitis C care program and the diagnosis testing, and for sure this will have consequences in the future. This has the HIV, the hepatitis C has reopened just in this month. So finally, this is my my last slide. I will explain that we made a collaboration with the Clínica Condesa Iner and Nutrición, and we looked for funders, and Fundación Carso gave us the opportunity to treat patients in a private hospital that is 17 kilometers away from the institutes of health. And we managed to go at the end of April, started this project to see patients that were in need of hospitalization. As you can see, most of them were in advanced stages of disease with very complicated diseases that were non-COVID, and that if it wasn't for this program, they would have died probably, because there were no possibilities of hospitalization in the city for reasons that were not COVID at the time of collapse in the previous months. So although we had a high rate of mortality, those people were really sick, and we managed to do something for patients in need of hospitalization because of AIDS-defining events. So in conclusions and perspectives of what has been happening here in Mexico City in terms of the HIV care, we will need to evaluate the impact of COVID-19 pandemic in the HIV care in Mexico City in the short and long term, because we do think the impact will be tremendous. We will need to think about creative strategies to increase the HIV testing, because as you can see, that decreased a lot in the first 2 trimesters, and the consequences will be important. And we don't have access to self-testing, and probably we will need to work more with the community to facilitate and give access to testing during this pandemic. We will need to do active testing because we are seeing the struggling now with many people that are lost to follow up because of the pandemic. And despite the crisis, we need the prevention programs. We need PrEP. Virtual consult and telemedicine is now part of our new reality. And more importantly, the collaboration of these 3 institutions have been really successful, and to look for patients. So I want finally to acknowledge all the people that has contributed to put together this presentation, and also to all our patients that have shown so much patience and also resilience during these months. And we want to dedicate this presentation to all the healthcare workers in Mexico City that have died, unfortunately, because of COVID, and especially to Jaime Montejo, and a very important activist for us in Mexico City that was the funder of one NGO, important NGO that helped sex workers, and also Adela, who was the personal assistant of Dr. Andrea Gonzalez. And with that, I thank you for all the attention. Thank you.
Dr. Crabtree Ramírez, thank you very much for that excellent overview of how Mexico City worked collaboratively within the different institutions and clinics to respond, sounds like successfully, to the COVID pandemic for persons living with HIV. I think you have raised a lot of issues which we are all grappling with. And so thank you again for sharing your work.
Thank you, Amanda.
So our next speakers are from Montreal, Canada. We have Sandra Wesley, who's the Director General of Stella Lamy de Mamie and Co-President of Montréal Sans Sida in Montreal, Quebec, Canada, as well as Dr. Sarah-Amélie Mercure, who's a Fellow of the Royal College of Physicians of Canada at the Montreal Regional Public Health, Infectious Disease Prevention and Control Department. So Sandra and Sarah-Amélie.
Yes, hi. So I'm Sandra. I'm the director of Sarah-Amélie de Mamie. We're an organization by and for sex workers. And I'm also co-president of our Fast Track Cities initiative here in Montreal.
And I'm Sarah-Amélie Mercure, and as Amanda just said, I'm a public health physician specializing in infectious disease. I was very busy in the last few months, and I'm also a KOL for Montreal Sans Sida.
So first I want to take a moment to acknowledge the land from which we're broadcasting today. Montreal is located on stolen, unceded Indigenous lands. The Kanien'kehá:ka Nation is recognized as the custodians of these lands and waters. Tiohtià:ke, also known as Montreal, is historically known as a gathering place for many First Nations before colonization, and still to this day, it's a home to a diverse population of Indigenous and other peoples. Canada, like every other colonial nation, is built on the continued and ongoing genocide of Indigenous peoples. In the context of HIV and of COVID and all other viral epidemics, we need to recognize that these epidemics are facilitated by colonial domination structures, and that they affect Indigenous and racialized communities with particularly devastating results. The legacy of the theft of our land, of slavery, and the more recent displacements of populations, refugees coming to our countries, are all coming out of this colonizing project that Europeans have enacted on the world. So it's important to keep that in mind as we talk about these viruses.
So I'm gonna present you some data, about COVID-19 in Montreal. I thought that Dr. Crabtree Ramírez data on HIV-specific care were very interesting. We're not gonna go in those kind of details in our presentation, partly because we don't have access to this kind of data from Montreal. But I think you'll find it interesting what we saw in terms of more generally health inequities that we could document in Montreal in our response to COVID-19. So as you can see in the lower right, our COVID-19 epidemic curve began very steeply because in Montreal, many people were coming back from spring break. So we had different events of introduction of the disease in the city of Montreal. So we were called the epicenter of the epidemic in Canada. We had a greater number of cases and unfortunately a greater number of deaths also. What we could see was that our acute care system was very well prepared. We never exceeded our capacity, but the senior homes were very, very hardly hit, and we had many deaths, and the living conditions in these places became inhuman in some instances. Next slide, please, Sandra. So I was talking about the inequalities that we could see in the pandemic and how our response sometimes exacerbated these inequalities. So I'll begin with gender inequalities. Here you can see that women were more affected by COVID-19 than men. What we can see is that almost 60% of cases were among women. We can explain this in a few ways. First of all, women are disproportionately represented in healthcare workers. So, not only nurses, but also orderlies and people who take care of the elder who are sick. So many women that caught the disease were healthcare workers that would then bring the disease back in their home and their communities. So we saw outbreaks in communities where women were more represented. Women were also more affected on the mental health side, we had a few surveys that showed that they were struggling with more anxiety and feeling of powerlessness. We also know that they were more numerous to lose their job because of the pandemic, struggling with domestic violence, and also they were more likely to have to take care of a household member who was COVID positive. What we saw is that men were more affected by severe forms of the disease, or so more likely to be hospitalized, and higher death rates also for men. We also looked at data to see if we had people, in the poorest neighborhood, if they were more affected by the disease, which is what we could see. So people from the more disadvantaged neighborhoods in Montreal were 2.5 times at higher risk of being affected by the disease than very affluent neighborhoods. And this difference is widening. The gap is widening. We see a very clear gradient among neighborhoods, which part of, it reflects inequalities that were there before the COVID-19, and that are just exacerbated with the pandemic. The reasons why these neighborhoods were hit harder are numerous. What we can think of is that these neighborhoods have a higher number of essential workers. So attendant, clerks, cashier, all of these services which made people having more contacts with other people, and having a more higher risk of getting COVID-19. It's also in these neighborhoods that we have a more crowded dwellings, so that people cannot self-isolate from their families in these neighborhoods. Also, we see that they are more likely to have less favorable living conditions, so they were more likely to have chronic diseases, which puts them at higher risk of a severe form of the disease. And also, they have less spaces to just go outdoor and not be in close contact with other people. We also ran a few analyses to see if racialized population were more affected. These are ecological data, because it was not possible in the survey, in the questionnaire that we would administer to people who were cases or contacts, to ask them if they would self-identify to some racialized communities, because the government, it was a governmental survey that we had to use, and it was not considered acceptable to ask the question. So it's something that we also see in our HIV surveys that we generally use, and it's a problem. We did some ecological data. So again, we look at the neighborhoods where we know that there are more numerous visible minorities, and here again we saw a gradient that in neighborhoods where there were a higher proportion of visible minority, the rate of COVID-19 was higher. Here again, we saw that women were more likely to, women from racialized communities were more likely to be affected by COVID-19. So partly because they are also numerous to be nurses' aid and nurses and orderlies. The reasons why racialized communities were more vulnerable to the negative socioeconomic effects of the pandemic are also numerous. So here we can say that they were more likely to have a financial loss, that they also were more likely to not be able to pay the rent, and to have someone in there also losing their jobs because of the pandemic.
So obviously the COVID epidemic had and is still having some major impacts on marginalized communities, which are the same communities that are affected by HIV. So the most significant thing in Montreal that is somewhat unique to Montreal were the extreme repressive measures that were enacted by the Montreal police, as well as other places in the province of Quebec. So public health measures recommending social distancing and urging people to stay home were used as a justification for police to give $1,500 tickets to anyone that they perceived that not respecting those measures. So obviously, as police tend to do, they targeted marginalized communities. We have reports of police giving a lot of tickets to homeless people, of going to target the same Black youth that they normally target, and instead of just harassing them or arresting them for other charges, they had this extra tool of giving tickets. Sex workers also received visits from police with threats of receiving tickets and also of arrest. So this has been a major negative impact on our communities. We're fighting to have these tickets removed. There were issues with drug supply. So obviously with the borders being closed, it makes access to drugs much harder. Prices fluctuate a lot in these circumstances. The access to just accessing physically a dealer can be very difficult. People's usual income streams are not always available. So sex workers might not be able to work. People who are used to panhandling might not see anyone on the street and therefore not receive money. This leads to an increased contamination of substances because they are produced in less than optimal conditions, and if there's not enough supply, then people have to do what they need to do to be able to use. Also increased surveillance because the streets are deserted, so those of us who remain on the streets are more visible, and police might also see a pandemic like this as an opportunity to increase repression against drugs. This also leads to an increase in violence, especially towards women who use drugs. This can be for many reasons, but whenever we're in a vulnerable position where we need drugs to get through the day or to survive, and those drugs are not available, it puts us vulnerable to many different forms of violence. For people living on the streets or in parks or in shelters, it was very difficult to access washrooms and water. Most people rely on washrooms in coffee shops or in malls and other public spaces. When those spaces shut down, this was catastrophic for a lot of people. And if we keep in mind that there's also repression, so if there's no washroom, but someone then has to go in a park, then they'll get a ticket or they might get arrested for this. So this created a lot of instability. There were some efforts to install some toilets in certain areas and some sinks for people to get water, but only in downtown areas and in very limited capacity. There was a big increase in social isolation for people living with HIV, especially people who perceived that they were at higher risk of COVID and therefore needed to be extra careful and stay home. For LGBTQ2S+ youth, and elderly people as well, who normally congregate in public spaces, and for many other communities. There were difficulties with housing stability and access to food for a lot of communities. And there was a lack of access to government aid for sex workers, for undocumented migrants, for anyone with a criminalized source of income. So there was this idea throughout Canada that we needed universal help for everyone to be able to survive the pandemic. But in reality, there was still this decision of who is worthy of receiving this money and who isn't. And criminalized income was explicitly excluded from these programs. So in terms of services, community-based organizations, most of us remained open with modified services. Obviously, this had a major impact on our workers and our health and our ability to manage also our own lives. Unfortunately, 3 out of 4 of our supervised consumption sites were forced to close for several weeks at the beginning of the epidemic because of a lack of masks and other equipment and a need for training. So we're in the middle of an overdose crisis where people are dying of overdose. And obviously, as we just mentioned, there was an increase in risk of overdose. And to have to shut down these places was extremely problematic and showed difficulties in prioritizing certain lives over others. In our minds, these sites should have been top priority to receive this equipment. And for a lot of these groups, from a harm reduction perspective, we're not going to let people die in front of our doors. We want to be open and be able to receive people, even if we don't have optimal protection. There were difficulties in establishing protocols to respond to COVID in HIV-specific housing resources. So we have several housing resources specific to people living with HIV. But because public health tends to be more concerned about preventing HIV transmission than actually supported people living with HIV, those connections weren't necessarily very strong or existent, and it was very hard to make sure they had access to equipment and make sure that they had a protocol in place for what to do if someone tested positive for COVID. There was a near total stoppage of all community-based or otherwise easily accessible testing for STIs, which we'll see in a graph is a pretty big problem.
So here we try to illustrate the impact on STI, on the number of STI that were detected and reported, of the fact that there was a very reduced offer of services, of screening services. There was also a reduction in demand for services, because all we were saying was stay at home, don't go anywhere that you don't feel is essential. So probably some people thought that HIV screening was not as essential as other services. And also what we know is that some people who were in need of a test would not go because they would fear of repression, because we were telling everybody stay home and don't meet people, and they were interpreting that if they still had sex and still were at risk for STIs, then they could not go and ask for a screening test. Maybe there was a reduced incidence in STI, we don't know, but for sure there was a big drop in the reported STIs, and now we are gradually coming back to normal, if you will, due to the gradual normal, to the return to normal of the services, and people being okay returning, asking for these services. We don't have data for HIV. Because HIV is not a reportable disease in Quebec, but we can extrapolate that these data probably also will be shown in the future when we have the surveillance report. We also looked at the tuberculosis screening and treatment services. And in these, in this case, there was not a lot of drop-in services. At the very beginning, there was an adverse impact on directly observed therapy, which was rapidly replaced by teleconsultation, which was actually an improvement in the life of people being treated for tuberculosis. And we have anecdotal but meaningful examples of early termination of treatment for tuberculosis due to the fact that we could not admit people for these long-term treatments because there were COVID cases in the place we usually admit these people. So the example I'm thinking about is exactly what we didn't want to happen. So a young lady of Inuit descent who was also struggling with alcohol problems, who could not get all the treatment she needed to clear the infection.
So I know time is almost up, so I'll try to go fast for these last few slides. So in terms of policies, things that have changed during COVID, a lot of temporary things were put in place, and we have to now think about whether or not we want to make them permanent, and if so, under what conditions. So temporary authorizations for expanded telemedicine services, including increasing the follow-up every 6 months instead of 3, and the ability to initiate certain treatments via telemedicine instead of an in-person meeting. Pharmacists as well, we're giving some extra powers to renew, transfer prescriptions, and even adjust some dosages. There was an official recognition that community-based organizations are an essential service. This is an interesting thing, as community organizations were constantly struggling for even basic recognition. So we need to think now about what this means for the future and how we can hold the government accountable regarding this. There was a universal income replacement benefit of $2,000 a month from March to September. This is a federal initiative. However, as I said before, it's not actually universal. A lot of people are excluded from these benefits. In terms of lessons learned, I don't know if we learned this, but we still need to repeat it. Criminalization, penalization, repression, all of these types of police or surveillance interventions do not work. They're not useful. We know this in the fight against HIV. It's a very clear thing. So we need a reflection about what public health officials can do to ensure that public health advice does not become a mandate for police intervention. And also the COVID crisis is a good opportunity to analyze our relationships between public health and politicians and how messages get transmitted to the population and how those powers need to be balanced. Public health officials have a lot of power, but if public health officials are not used to engaging with this power and exploring it and feeling confident in it, it's very easy for politicians to overtake the conversation and become the leaders, and they will always be more repressive than the experts because it wins elections. So testing can and should be demedicalized in many ways to remain accessible if the medical resources are mobilized elsewhere, and also for convenience for people in the community. Another point, we need to seriously address how we communicate information and how we respond to things like conspiracy theories, to information that's stigmatizing. We need to be able to build actual trust, and that involves not oversimplifying messages so that communities are not hearing things that we know are not actually true. We've seen this in terms of STIs. If we're told that we're definitely going to get HIV and die if we have sex one time, we know that's nonsense and we're not going to follow it. And with COVID, there was a lot of this back and forth in terms of finding the right balance and dealing with new information that's being put out. So communication of public health knowledge that's still in motion is something that people need to look into to better prepare for next issues. Community-based organizations are indispensable in a crisis, I would say at all times as well, but especially in a crisis. And we need to be part of preparation for emergencies. We need to be at the table very early on in the process and continue to be. We shouldn't have to fight to get a seat at the table. And then we can't rely simply on pre-existing friendly relationships between certain individuals in different communities. We need to have a structure that sees community-based organizations as an important partner of all public health actions. Communities affected by HIV, we are used to being in pandemics, to living with viral risk. We have developed good reflexes around testing, around hearing public health advice in a way that doesn't send us into a panic. And we're therefore able to make the best decisions for our situation. And we have a lot to teach the general population about how to live with these new realities. And this expertise should be valued and put forward. And community-based organizations are able to quickly adapt new services, produce documentation, create new programs, but we need the necessary support and resources. In Montreal, a lot of stuff happened very quickly through organizations. We started, CommunityBased, for example, started a program for migrant people who didn't have access to universal healthcare. Food banks adapted their services really quickly. We produced financial documentation to help people navigate the new reality of COVID. New distribution methods for harm reduction material, such as using bikes and other things like that. Online services to reach our communities. programs to deal with the isolation, specifically in the Black community. One of our organizations, GABV, had an amazing program to pair up people so that they wouldn't be so isolated. Organizations provided camping equipment for homeless people so they could set up in parks instead of get infected in shelters, and many other things that were done very quickly by our community organizations. All right, that concludes our presentation. Sorry for going over the time.
Thank you very much. Thank you very much, Sandra and Sarah-Amélie, for a really comprehensive presentation that helps us to understand the context within which Montreal has really responded. And I specifically want to thank you for starting off by reminding us of these long-standing historical context for many of the inequities that we are observing today with both HIV and that have been exacerbated by the COVID-19 pandemic. So we're going to move on, and our next speaker is Dr. Anisha Gandhi. She will be speaking about New York City. She is the Acting Assistant Commissioner, the Bureau of HIV at the New York Department of Health and Hygiene in New York City. Dr. Gandhi.
Good morning, everyone. Just give me 1 second. Okay. Okay. So good morning, everyone. Sorry about that. Thank you so much for the introduction. I'm Anisha Gandhi, the Acting Assistant Commissioner in the Bureau of HIV at New York City's Department of Health and Mental Hygiene, and happy to be with you today to share a little bit about our local COVID-19 epidemic, as well as some of the changes and adaptations we've made in our HIV and other infectious disease services and programming, as well as some of the trends we've observed around testing in this context of COVID-19. So I'll begin with sharing a little bit about our local COVID-19 trends, and as well as some of the observed inequities in those trends. So as you may know, it's certainly been splashed all over a lot of headlines. New York City in late March was declared as the national epicenter of the COVID-19 pandemic for the United States. To date, we've observed over 231,000 cases, over 57,000 hospitalizations, and over 19,000 confirmed deaths in New York City alone, with an additional 4,600 deaths that were probably attributed to COVID-19 as well, but in the absence of a positive laboratory test. So as you can see in this histogram, our epidemic really peaked thus far in late March and April, and acknowledging that a lot of those early cases were very severe because of the lack of testing and personal protective equipment. We were really limiting testing to people who were symptomatic and had more severe cases. As we moved further into the spring and early summer, testing became more widespread and accessible, so that included more people with milder symptoms and even asymptomatic individuals. However, we know that like many of our other infectious diseases, COVID-19 is not evenly distributed in New York City. So here you see a heat map of our New York City neighborhoods with the darker shading representing zip codes and neighborhoods that are more, that have higher COVID-19 case rates. And this, as you can see, is concentrated especially in what we call the outer boroughs, so in the Bronx and in parts of Queens, where especially immigrant communities and communities of color are more concentrated in terms of the demographics of those neighborhoods. And this breaks that down a little bit more. We've seen throughout the pandemic experience really marked racial and ethnic inequities and disparities observed in cases, in hospitalizations, and in deaths related to COVID-19, with Black and African American individuals and Hispanic and Latino individuals being more likely to be a COVID-19 case, be hospitalized, or to perish in relation to COVID-19, while white and or Asian Pacific Islander people have been less impacted. And so just to get into those specific numbers, we see that these case rates among Black and Latino and Hispanic people are actually much, much greater than those among Asian Pacific Islander people and among white people. And the case rate we also see to be much more heavily distributed in very high poverty neighborhoods, which is defined by 30% or more of a given zip code living below the federal poverty line, in comparison to those case rates in low poverty neighborhoods where less than 10% of the population is living under the poverty line. So we know that these inequities are not just something that is, kind of anomalous to COVID-19, that this really tracks with our HIV and other epidemics, and really demonstrate the kind of pervasive consequences and impacts of systemic racism, xenophobia, and other forms of oppression that create unequal opportunities for health, for access to healthcare, and for economic opportunity that really can help mitigate COVID-19 risks for people as they live there and work in their daily lives. And these unfortunately carry over into our death rates as well. So we've seen death rates are among Black people and Latino and Hispanic people are twice or more than twice that observed among white and Asian Pacific Islander people in New York City. And again, we see this really reflected as well in terms of seeing disparities and death rates being more than twice as high in very high poverty neighborhoods compared to low poverty neighborhoods. So I want to share a little bit about the impact of COVID-19 on HIV, STI, and hepatitis testing in New York City and what that's looked like. And largely that we are able to do this by comparing that volume of testing done in the same months in 2019 compared to what we've seen in 2020. So want to note that I'll start with this bottom piece, that from March 2020 onward, our epidemiology program, which is really the central crux of our ability to conduct HIV surveillance, it ceased on conducting that on-site data collection that really contributes a lot to our surveillance measures. So we've really reduced that, not only out of adherence to public health guidance and keeping our staff out of these in-person activities, but also because many of our staff have been deployed into supporting our COVID-19 response. And so our data collection has been done via alternative means, including phone, e-fax, and remote access to EMR systems. And so that has really limited our ability to confirm new diagnoses of HIV based on HIV diagnostic test results. And so kind of in correlation to that, and partly has contributed to our observed substantial decreases in HIV-related laboratory testing volume that we've received in our health department. And so from that was really demonstrated in those early months of the epidemic, when a lot of clinical services were very much reallocated to COVID, where a lot of elective medical visits that were not related to urgent health issues, people were delaying or were discouraged from attending to help control the COVID-19 epidemic here. And so saw these decreases across the board for HIV-related laboratory tests. The volume of those tests appear to rebound somewhat for people living with HIV, but that decrease in diagnostic tests has not yet rebounded in the same way. So demonstrating that more visually, these blue bars represent the test volumes in 2019, in this case for CD4 tests, and the red bars representing 2020 volumes, and also showing the % decrease compared to 2019. So really corresponding with the explosion and the peaks of our epidemic to date, seeing these really marked decreases in those CD4 test volumes in March and April, and in May, and then beginning to rebound as we hit the summer and the COVID-19 sort of volume and impact decreased here. This was also observed in the viral load tests, again, really marked decreases in March, April, and May, with that rebounding in June and July in comparison to 2019. And then finally, those diagnostic tests, as mentioned, we've not really seen that same rebound just yet. We've seen really quite a marked decrease from March and especially from April onward in terms of those tests being done. And I think much of what has been shared from others applies here too, that, that some of that may be due to clinics, in-person clinics being closed at the beginning of the epidemic, or really clinical services were limited and relegated to COVID-19 related issues or much more serious illness. So also to note that like other places, we are looking at the relationship between COVID-19 and HIV, and especially trying to determine whether COVID-19 has disproportionately impacted people living with HIV. So using matched data along with additional data from our surveillance registry, we will be conducting a more detailed analysis, which is already underway. A publication is forthcoming to really look at the demographic characteristics, and then among people living with HIV, both with and without COVID, identifying whether there are differences in those populations, and then among people living or who have been diagnosed with COVID-19, comparing people with and without HIV diagnoses to identify whether there are differences in the severity of experience or outcomes or demographic traits. So stay tuned for that. In terms of our STI testing, looking again at our citywide surveillance data, we compared case counts for the same months in 2019 versus 2020 and found decreases in 2020 for chlamydia and gonorrhea case counts and diagnoses, but not as much of a change for primary and secondary syphilis, and did not find the distributions of these cases to be significantly different with respect to age, reported sex, or borough or neighborhood of residence. So demonstrating that visually, again, 2019 in blue, our 2020 comparisons in red, with those cumulative counts of cases appearing in the dashed lines, seeing again in March and April those much more dramatic drops of chlamydia cases. And this certainly, we can imagine that, that part of what may be attributing to that drop is that chlamydia cases also, there's likely a drop in diagnosis of asymptomatic cases. While as these drops were a little bit less dramatic for gonorrhea and rebounded more, and it's likely that that was contributed to by the virtue of gonorrhea cases being more likely to be symptomatic. And then we didn't observe the same trend in quite the same pronounced degree with primary and secondary syphilis cases when comparing 2020 in blue to 2019 in blue to 2020 in red, likely because you know, these syphilis cases by definition are symptomatic, so more likely for people to seek out that care following symptoms. And then with respect to our hepatitis B and C viral load testing, new diagnoses decreased substantially in March 2020. These are increasing again for hepatitis C, but still seeing that diminished diagnosis rate for hepatitis B that is not quite rebounded in the same way. We've seen also among those diagnosed, the viral load tests having decreased as well. So just to demonstrate this visually with hepatitis C, you can see this again following these same trends of really like those drops in March, April, and May that are leveling off a little bit as we move into the summer. I'll share a little bit about how we've adapted our HIV and sexual health services programming during the COVID-19 pandemic. So as mentioned, we've adapted and really modified a lot of our surveillance and partner services to make sure that we don't contribute to the spread of COVID-19 as we try to take care of newly diagnosed individuals. So interviews with those newly diagnosed with HIV, as well as out-of-care clients and their partners, are now occurring via phone, Skype, and FaceTime. We're speaking with providers by phone and still making sure to link clients and their partners to service providers that we have confirmed are still seeing patients either by telehealth or in person. We have still continued to maintain our intra and interstate deduplication efforts, database matches, and quality assurance activities related to HIV to make sure that we are keeping up with our, as much as we can, with respect to confirming the accuracy of our surveillance registry and other data. New York City has runs 8 sexual health clinics, as you can see in this map, that are scattered across 4 of our 5 boroughs, and really we do our best to make sure that those are distributed in higher needs neighborhoods. And 3 of those 8 clinics are currently open and offering limited and sexual and reproductive health services, including PEP for HIV, emergency contraception, HIV treatment for people starting treatment for the first time, urgent follow-up for patients that are contacted by clinic staff, HIV and STI testing for people ages 21 years and younger, and medical evaluation for signs and symptoms of STIs and HIV, as well as some contraceptive services, including appointments to provide people with IUDs, intrauterine devices, and the implant. And we also are offering daily telehealth appointments for much of the day for HIV and STI services. Our tuberculosis services have also been adapted. So we have 4 tuberculosis clinics that offer comprehensive care. New York City actually has, I think, twice the diagnosis rate or case rate of TB compared to the national average, and it's heavily concentrated in our immigrant populations. And so we continue to maintain services, but at a reduced capacity. Much of those services have been shifted to telehealth with really only necessary appointments happening on site. Like other places, we've also shifted DOT to telehealth, as well as some of the physical evaluations. But home visits and in-person visits are still occurring, with those home visits really occurring among patients prioritized who really lack access to either the technology to be able to conduct telehealth appointments or visit the clinic site due to, again, lack of resources or kind of that transportation issues. So in terms of what we've been trying to do outside of those really kind of concrete clinical services, we've done what we can to really support our communities, our providers, and our community partner organizations. Some of that has been done through offering concrete guidance, through issuing a number of Dear Colleague letters that have been done in collaboration with our New York State Department of Health. So a number of those came out specifically acknowledging kind of guidance to follow for around COVID-19 testing and the receipt of medical care for people living with HIV, and updated that as more information came in, best practices around PEP and PrEP. And then want to especially highlight our Safer Sex and COVID-19 fact sheet, which garnered a lot of national attention in mainstream media. It actually got picked up on a lot of our late night shows and in some comedian stand-up, I think partly being highlighted because we really spoke to a lot of questions that people may have, but maybe aren't getting answered in all potential outlets and through other either health departments or health-related organizations in terms of what kinds of sex acts, sex play, and kind of partnership dynamics might be people may be able to engage in more safely to prevent additional spread of COVID-19. So this phrase, "you are your safest sex partner," really ended up echoing quite widely in our mainstream media, and then I think helped direct a lot more attention to our site where people could learn more about COVID and other health services that were ongoing and available throughout New York City. We also did our best to support our contracted providers, really trying to identify resources that could be shifted or reallocated to make sure that not only were HIV services being maintained in whatever ways possible, but also those kind of wraparound holistic services that people vulnerable to or living with HIV really needed in this time of a lot of uncertainty and economic insecurity, and for many, housing instability as well. So provided technical assistance. We support and fund a lot of contracted providers that are on the ground in a lot of our communities. So facilitated shifts to cost-based reimbursement to allow a lot of community-based organizations to stay open even while the volume of services they were providing while we were in various phases of being closed and open, and demand shifted for them to continue to be able to operate and keep their doors open. We also maintained an online directory of providers in our Place Your network to make sure that that in real time community members accessing our website were aware of where they could get HIV and STI testing, PrEP, PEP, HIV care, and navigation and supportive services. We also leveraged our Ryan White Part A funding and our federal funding through the CARES Act that was part of the emergency COVID relief packages to expand food and nutrition services, emergency financial assistance, and short-term rental assistance, particularly for people living with HIV. We are also supported to provide capacity building assistance to a number of other health departments and jurisdictions, and so have been continuing to do that work virtually, facilitating peer-to-peer learning opportunities, and providing a number of institutes and specific learning opportunities around LGBTQ+ care, condom distribution as a structural intervention, and syringe service programs. We have continued a lot of our community engagement through virtual meetings and town halls with our planning bodies, community partnership collectives, and advisory boards, have maintained weekly e-digests and email blasts on COVID-19 related topics, not just restricted to HIV, but including coping with grief, food and financial assistance, telework, and tips on protesting safely in the wake of a lot of racial trauma and racial justice protests in New York City and beyond. And also participated in virtual Pride events. So you can see here our Deputy Commissioner, Dimitri Daskalakis, DJing for a set during our Pride at Home event. A couple things I'll highlight quickly. We also have adapted some of our services, including our condom distribution. So we, in June, launching door-to-door, a service in which New York City residents can order free safer sex products for home delivery, including both condoms and lubricant. And these are discreetly packaged, again, keeping our New York City community members safe. And have also adapted some of our very successful home test giveaway programs. And so in the wake of COVID, have partnered with even more community-based organizations to allow New Yorkers to access our online giveaways through dating apps and other digital media, as well as community partners. They then receive a voucher to be able to claim a free HIV home test and access to 24-hour support services that in case they should need it following receiving their test results. Some lessons learned, we have really done our best to leverage technology to maintain service continuity, to continue to engage community stakeholders and partners, not only to get updates, but to really be true partners and co-creators in adapting services to best meet community needs in our evolving kind of response to the pandemic and with these various phases of reopening, and really making sure that we meet needs of localized specific communities, both living with and vulnerable to HIV. We also have done what we can to be creative in expanding awareness, reach, and innovation of our programs, again, really leveraging social media, websites, and other forms of technology. We have also found that addressing needs for sexual health information and resources are, again, ways to keep people engaged and making sure that we potentially open opportunities for them to take care of other parts of their health needs. It's been important for New York City to monitor and work to address inequities, especially our racial, ethnic, and economic related inequities that are exacerbated by COVID-19, and do what we can to respond to holistic needs of communities, not only in providing clinical services, but also wraparound housing, financial, food and nutrition, and mental health services as well. Thanks so much. Feel free to reach me with any questions or inquiries related to this content.
Thank you, Dr. Gandhi. That was a wonderful presentation. And I think that it's fair to say that while New York City started off as being an epicenter of COVID-19 infections, it quickly transitioned to being a model, not only for how to respond to the COVID-19 pandemic, but also to how to continue and try to maintain the continuity of HIV services, at least for the United States. So it'll be interesting to see the follow-up results from your match with COVID and HIV registries, and also to see how STI diagnoses and TB diagnoses are impacted in the long term. So again, thank you for sharing that very comprehensive overview. Our next speaker is going to be Dr. Carlos Del Rio. He's going to talk to us about the Atlanta, Georgia experience. Dr. Del Rio is a distinguished professor in the Division of Infectious Diseases at Emory University School of Medicine and Executive Associate Dean at Emory University at Grady Health Systems in Atlanta, Georgia. Dr. Del Rio?
Hey, Amanda, how are you? Can you hear me?
Thank you for joining us.
Delighted. I'm sorry, I'm in clinic right now seeing study participants, so hopefully this will go okay. So anyway, it's a pleasure to be here with this panel. And can you see my slides?
Yes, we can see your slides.
Okay. Well, let me just again highlight for our international colleagues. I know New York was on the call, but we have Mexico, we have Montreal and other cities. That through yesterday, the U.S. has had over 6.5 million cases and close to 200,000 deaths as a result of COVID. Where I am in Georgia, we're close to 300,000 cases and over 6,000 deaths. And Georgia is number 5 in the U.S. And we are seeing a decrease over the past week. Georgia has seen an average of about 1,700 new cases, and this is a decrease of almost 30% of the average 2 weeks earlier. So we are making a change and we're coming down, but we got a really bad epidemic happening over the summer, very uncontrolled. But from a national perspective, you can see here the numbers. I mean, tests have come down a little bit in the US, cases are coming down. Hospitalizations, we have this funny peak phenomena. Deaths are not coming down as much as you want. You're still having about 1,000 deaths per day. But this is very different from regions, as our previous speakers mentioned. Dr. Gandhi said the Northeast, where the epidemic started, and you can see there in March, April, where they had a big surge and it had a lot of deaths. They have pretty much controlled their epidemic. Well, here in the South, we kind of came late. As you can see from this graph, we never really had a second wave. It was just an increase, sort of an exacerbation of the first wave. And our deaths have sort of plateaued and are still continuing. So we're not controlling the epidemic as much as other places in the country. And just talks about the US not being one country, but multiple epidemics happening simultaneously in different places, and each epidemic being different. Getting down here to Georgia, you can see here, when you look at the average cases per day, even though Atlanta, where I live, is a major metropolitan area, we're doing much better here because we have had a mayor that put mask mandates and other things. But you can see a lot of the rural counties is now where the epidemic is growing faster, and I'll mention some of them. Nevertheless, we're still having about 1,400 cases per day and about 20 to 40 deaths per day. The big issue has been, like in the rest of the country, has been the racial and ethnic disparities in COVID. And you can see here from our data in the state, cases in Hispanics, despite the fact that the state is significantly African-American, you can see that in Hispanics, cases are almost 3,000 per 100,000 populations. And the deaths are different. Deaths are higher in African-Americans at 58 per 100,000 population. So more cases in Hispanics, but more deaths in African-Americans. And we need to really study and understand this because it's not very clear yet why this difference. As I said, Georgia is doing a little better. 2 weeks ago, we had over 30 cases per 100,000 population. We're now down to 16 cases per 100,000 population. But still, we're not where New York and other places are, which are less than 5 cases per 100,000 population. So we're not controlling an epidemic as much as we should. And you can see here that in Georgia, a big problem has been contact tracing. We really have not done a good job in contact tracing, even though we went from 8% to 16%. The great majority of cases are not being contact traced. I don't know what happened here, but in this slide, you can see about the counties with the highest number of cases and death rates. And again, this is what I was trying to say. Chattahoochee, Berkeley, those are very rural counties. So the epidemic has moved from urban to more rural communities. When I focus in Atlanta, Atlanta is a city that it's comprised of 20 different counties. We don't have a city health department. We have county health departments. Our major counties are Fulton, DeKalb, Cobb, Gwinnett, and Clayton. Those are the 5 big ones. But it's really this group of 20 different counties that actually makes the Metro Atlanta area. And you can see how different they have been and how cumulative cases are very different. And despite the fact that Fulton and DeKalb, where most of the cases have occurred, you actually have Gwinnett there with 25,000 cases. And Gwinnett is there because, quite frankly, this is where a lot of the chicken farming industry is, and a lot of Hispanics work in the chicken farming industry. Here you're looking at the newly daily confirmed cases, and again, you see this decrease that is happening, but there's certain counties that are very heavily impacted, and again, many of them are the counties where a lot of Hispanics live. We have created, together with the mayor's office, an Atlanta dashboard that is updated every week, and you can see right now that we went up we got all the way to phase 2 in the early summer, but then with the peak in the summer, we actually took the city back to phase 1. We're currently about to exit. We're making progress about to exit phase 1 because we can see there are criteria of how do we get out of phase 1, and we're probably by the end of this week, we'll be back in phase 2 as cases are getting out. Cases have been out of the red zone and they've been in the yellow now for 19 days. Hospitalizations are also down, and so is a positive rate of test results, and bed availability has gone up as well as testing availability. I wanted to highlight the study done by my colleague Lauren Collins and recently published in AIDS, in which she looked at patients with HIV who had COVID-19 that were hospitalized, and she looked at a total of 20 or so patients. Again, given the big population of HIV patients we have in Atlanta, we were expecting to see a huge number of cases, and we really haven't. So that has been a surprise, really, that the impact on HIV has not been as significant as we thought it would be. And many of them have comorbidities, but most of them have done actually quite well. Those that got hospitalized did no different than those that didn't have HIV. And in this series, really, almost all had controlled HIV. And so again, highlights that it's not necessarily HIV, and that people with HIV, at least here in Atlanta, are really no different than people without HIV. But they may be a little younger, they may have more comorbidities, and that may be what's driving the severity of disease in some of these patients. I want to also make you aware of something we developed here at Emory, which actually has national significance. It's called the COVID-19 Health Equity Interactive Dashboard. And if you go to this website, you can actually look at the county level. And we're trying to allow people to look at disparities, and you can really look at disparities in the US and in Georgia. And you can get down to the county level and really look at your information, look at where you are, how do you compare to the national, but more importantly, you can look at the distribution of cases. You can look at something that is called the Community Vulnerability Index, in which we're putting along risk factors and community factors, like, for example, poverty and where you live and your zip code, and putting them into context to see where counties rate across the state and where people are rating. Also, you can look at different variables. For example, here I'm looking at Fulton County. And in Fulton County, you can see, 43% of the population is African American compared to 31% of the states and only 12% in the US. But you can see in diabetes, for example, 8% of the population of Fulton has diabetes compared to 13% in Georgia and 10% in the US. You can see for each one of the risk factors that we're looking at, Hispanic, obese, poverty, uninsured, how do they compare to different places? And you therefore can look at what is the vulnerability index for individuals and what kind of interventions are you needing in order to address this population. What are the programmatic consequences that we've had from COVID? Well, the great majority of clinic visits transitioned to telemedicine. The good news about that is that many people who were out of care actually returned to care. They returned to care through telemedicine, which I think is teaching us something about retaining people in care. There was a significant drop in STD clinic visits, but PrEP has been continued quite well. We have seen a significant drop, though, in HIV testing. So what is the world post-COVID is going to look like? And I think, that COVID we've known for a long time that we need to make HIV testing, STD testing, and treatment much more convenient and more patient-centered. And I think COVID is finally forcing us to do this. It's finally forcing us to really look at the way we're doing things, the way we act. And I want to be optimistic and say we should not miss this opportunity. I don't want to return to the world it was before COVID. I want to go forward to a better world. And I think we can do a lot more things in clinic and in our healthcare system that would really be more patient-centered as a result of COVID. And with that, I'll end and happy to turn it over.
Thank you very much, Dr. Del Rio, for giving us the landscape of COVID in Atlanta, Georgia, and for also just reminding us from the clinical standpoint. As you said, I think a lot of us were poised and ready to see dramatic number of COVID cases among people living with HIV, and were somewhat surprised and reassured to see that we really are not seeing differences among people, at least who are virally suppressed and on antiretrovirals. So we do have just a few minutes where we can do a little Q&A session. And I'll start out by maybe directing this question to all of the panelists. So one of the big issues that we are considering, at least in Washington, D.C., where we also have about 2% of our population living with HIV, is how will we move forward post-COVID, and what will be the role of telehealth and more virtual outreach to our individuals who are either living with HIV or those that are, getting preventive services for HIV. So does anybody want to start us off there? Maybe Dr. Del Rio, since you said you're in clinic right now, are you doing in-person clinic, or are you now in a position where you're...
Currently, I'm not in our HIV clinic. I'm actually doing study visits for the Moderna study right now. So these visits have to be live, and we're enrolling people in a COVID vaccine study. But I can tell you that clinic has been different. I think one thing that we've learned is, younger people, for adolescents and young adults, telemedicine, they love it. People that were not, our biggest retention problem is with young people, and all of a sudden they come back to care through telemedicine. But older individuals really don't like telemedicine. When we started having people come back, my patients, and I'm talking older, anybody older than 45, 50, they're like, oh my God, I'm really happy to see you. I'm really happy to be back. They're not just, they were not as happy with telemedicine visits, and they want to be seen in person. So I think we may need to have a different way of approaching, a different way of seeing people. I think, there's also some significant in the US, I'm going to be very US-centric right now, but there's some significant policy opportunities. Why do we need to have people come every 6 months for their, viral loads? What other things we can do? How can we be more open to different approaches, to do more, again, more patient-centered? Why do people need to waste the whole day to come to clinic? I think for PrEP, there's a huge amount of opportunities. I also think, and I'm sorry we're not doing this, but I've been pushing this, is that given that the same population is impacted by HIV and by COVID, why are we not incorporating testing for these diseases? Why are we not, when we're out there in communities now testing for COVID, why are we not also offering testing for HIV, for STDs, for hepatitis? Because we have the opportunity to be in the community. Why do we need to be, disease vertical and disease centric? So I really think we need to be more creative in our approaches. And I think, again, there's a huge opportunity to have major policy changes that will impact how we do things locally and globally.
Thank you. Dr. Crabtree Ramírez and Sandra and Sarah-Amélie, I don't know if you all want to speak to that as well. I know, Dr. Crabtree Ramírez, you mentioned that you all had, basically said that patients who were virally suppressed and who were stable didn't necessarily have to come to clinic. And then also for Sarah-Amélie and Sandra, as community-based organizations as deemed essential workers, you know, how are you all pivoting to make sure that your clients have access?
So my understanding is that COVID has forced us to do different kind of clinical monitoring. And I do think we are now finding out that many of our monitoring is not necessarily for all of the patients. And there are some patients that are in need of every 6 months monitoring of viral load, but not everyone. So I think not necessarily everything suits to every kind of patient, as Carlos del Rio mentioned. So it is time that we analyze how this new reality that we were forced to implement because of COVID could then in the future function and be effective for HIV monitoring. We in Mexico, we don't do this community level as we should do for testing, and I agree that we should use our resources that we have to in the community to, for example, to test for diabetes that is really common. It's a very health problem in Mexico. To use that for COVID testing, for HIV testing. So use the resources we already have in place, and that will now be the way that we can move to have more testing in many diseases and not only for HIV. And I think the community of health providers and HIV patients has adapted to many ways along the last 3 decades. And I think that gives us many lessons and path to the future of how we can handle both of the epidemics.
For us, telemedicine and other forms of, you know, whether they be by Zoom or on the phone, those types of consultations, they're very useful for certain people. But for a lot of us, they're just absolutely unacceptable for many reasons. A lot of us don't have access to a phone or to the internet or to anything that would even make it possible to have those types of appointments. Some of us don't have privacy at home. And when we're forced to have these consultations in those ways from home or from public spaces, well, then there are major risks in terms of confidentiality and all of the consequences that can come with being outed. And sometimes we don't have the capacity to communicate in such a way that phone conversations are useful for us. So we need to really maintain in-person services as well. But on the other hand, we found that for some people, the fact that you can have a phone conversation without video can make it so that you don't get the standard speech about being too fat and needing to lose weight instead of actually addressing your health issue that you're consulting for, that you might not be discriminated against in the same way if the way you get discriminated against is based on your appearance. So there are benefits and issues with remote consultations, and we need to be able to adapt to that. And then the other side of this, for community organizations, services directly in our communities is an absolutely essential, central aspect of all of the work that we do. And that ends up being the first things that we cut. And we need to make sure that in moments of crises, we prioritize those types of services. To us, it makes no sense that up to this day, we still haven't resumed doing STI testing in our own office with a nurse. That it's going to be the last service that gets put back in place. So we need a variety of services that respond to everyone's needs. And as I was describing, a lot of the issues for marginalized communities when we interact with clinicians is this expectation of discrimination, and that's ultimately what we need to work on. And when we notice those things, well, clinicians need to be aware that we're constantly putting in place strategies to mitigate that risk, and that is a big barrier to effective clinical care. And so when we notice these things, we need to address the fundamental issue as well.
I was going to say exactly the same as Sandra. Not all people have a phone or a computer or want to do this way. So I think that what we need to learn about all this is that we can do it very, very fast. We didn't have an infrastructure for telehealth in Quebec at all. Physicians could not be paid for telehealth consultation, and it took, I don't know, a week or two before all this, it just happened. So I think that we need to learn that we are able to adapt to the needs of the patients. So maybe that's the biggest lesson that we need to learn, and everything else that my colleague said, that we need to go where the patients needs to go for his or her consult.
Yeah,
So as the saying says, necessity is the mother of invention, right?
Yeah, and the big issue is that what is considered necessity varies a lot. And in this case, doctors not being able to get paid if they spoke to their patients on the phone instead of in person was the necessity that led to a very fast, immediate change. We need to be able to have the same fast reaction when communities are saying we're dying of overdoses, can we get prescription heroin? That needs to be seen with the same urgency as doctors not getting their money.
Or buprenorphine waivers, right? I mean, why do we need to?
Do you want to just give us a little bit of how you think the New York City Health Department is going to, are many of these programs that have been put in place in response to the pandemic going to move forward, or how do you see things pivoting? And I know that your city really has been a leader in prevention around PrEP. And so if you could just quickly tell us about that.
Sure. I think echoing much of what's been said, I think we shifted from this idea of this like very sort of monolithic model of prevention, 10 or 15 years ago, especially before the advent of PrEP, and now really think of it much more like a toolbox of like and especially as we move into like the realm of injectables, we want to give people options so they can make the choices and engage in healthcare in the way that works for them. And I think especially given we don't know where this pandemic will go, I think many places in the US are needing to be prepared not to face another March or April for us. So if in the event of a resurgence or an ongoing thing where we're dealing with this pandemic, I think giving people more of those options, we've seen the ways that actually not having to come to a brick and mortar site has reduced inequities in some ways. So to me, it's also about making sure that anyone who wants telehealth really has that available to them. What are ways we can get devices into people's hands? What are ways that we can create safe spaces for people who aren't safe at home to still engage in telehealth if it's not safe for them to be on the subway, if it's not safe for them or accessible for them to get to a clinic? And so I do agree that I think a lot of things that seemed impossible 6 months ago have now become possible. And I hope that we just push in collaboration with, we are fortunate to have very strong, vocal, staunch advocates in our community-based organizations. And I hope and have confidence that in partnership with them, we will continue to push political will toward making sure that there is more flexibility in how people receive prevention and care.
Well,
I'm into that.
So we're out of time, but I do want to thank you all for these wonderful presentations, for taking us on a virtual tour of North and South America, and the response to the COVID pandemic. Thank you for all of your work. And I think you've highlighted the importance of, longstanding inequities that we've seen with HIV that are now being, again, highlighted and exacerbated with the COVID pandemic and these syndemics that are occurring. And I think it will be very interesting as we move forward to see, what remains in place, how we've been able to pivot and adapt to this new situation. And, really, as you all said, to make sure that we have options that meet the needs of all people who are living with HIV or who need, access to preventive measures. So, time will tell. And of course, we will also see how things roll out with the vaccine amongst these populations that we care for as well. So thank you all very much. Thank you to those that were able to join us virtually. And I hope you all continue to do good work and to be well. Thank you.
Thank you.
Thank you, everybody.
Thank you.
Bye-bye. Thank you.
Bye.
Bye-bye.